Hi, this is Manos Berlakis, and this is case 192 for the Manual of Percutaneous Coronary Interventions. This is a case in which advancement of the 0.035-inch wire into the aorta was challenging. The patient was referred for complex percutaneous coronary intervention. We did choose femoral access because of the complexity of the procedure, and we obtained access using standard techniques, including fluoroscopic guidance with a forceps, as well as an ultrasound guidance and micropuncture needle kit, slightly high entry point at the top of the femoral head. However, angiogram done after obtaining access shows good access point. The access is below the inferior epigastric artery. We did insert a long sheath and then try to advance a catheter all the way to the ascending aorta. However, the wire would stop before getting into the aortic arch. So what to do? We ended up obtaining access on the left, and then we did an intravascular ultrasound to try to determine what was happening on the aorta. And these are the images from IVUS, and it's hard to know for sure, but there appears to be some sort of flap. There is not what we'd expect in the vessel structure. There's some movement, and this is concerning for potentially having an aortic dissection. So what to do next? We did have a true lumen from the left femoral axis. The catheter was all the way into the aorta. So we did aortograms. This is starting from the aortic root, and fortunately the ascending aorta looks okay. However, we're starting to see some extra contrast along the side of the descending aorta that is concerning for dissection, which actually was confirmed when we did another picture a little further down. We do have essentially the wire coming from the right femoral axis being outside, likely in an area of dissection. Continuing further down, we fortunately had good flow into the renals as well as the superior mesenteric artery. And then going at the aortic bifurcation, we see that the long femoral sheath placed from the right femoral axis is actually going in a dissection plane. So what likely happened is the guide wire entered a dissection plane, and then we extended dissection all the way up to the ascending aorta. After this, we pulled the sheath back, and there was good undergrade flow. So we stopped the procedure. The patient went to the recovery room, but then the patient started having significant chest discomfort. So he went for an emergency CT for dissection, which confirmed what we had seen on the aortic root, that is, that there is an extensive dissection going essentially all the way down into the right external iliac artery. So what we have is dissection that fortunately does not extend past the origin of the left subclavian artery, but then we do have dissection. This is the descending aorta. Again, there's a dissection plane. With the dissection extends a little bit on the SMA, but there is good flow. We see that the renal arteries are coming from the true lumen, so the perfusion of the kidney is preserved, but then it continues past the bifurcation into the right common iliac and then into the external iliac. And these are the coronal views, and this shows a little more clearly the extent of the dissection. Essentially, the dissection goes all the way to the origin of the left subclavian artery, and then continues down into the descending aorta, abdominal aorta, and then goes into the iliac artery. In this illustration, what we have here is a type B, Stanford type B aortic dissection, which usually stops at the left subclavian artery. It's fortunate we did not have a type A because type A requires emergency cardiac surgery. So we had a type B aortic dissection, and the treatment for this, unless major branches are compromised, is to control the blood pressure and provide analgesia, and this is what was done in this patient. Several lessons from this case. The first one is humility. Despite doing several cases, complications can still happen. This is the first case I have personal experience of causing a dissection from the iliac artery all the way to the aortic arch. So keeping humble is important. Things can happen at any stage, and one needs to be very alert to diagnose such complications. The second is that if there is any resistance to advancing a guide wire, whether this is 0.035 or 0.014, it is important to avoid exerting force and trying to be as gentle as possible to prevent any complications. But if there is such resistance, then dissection should be considered. How to diagnose dissection? In this case, the Aortogram demonstrated. Sometimes a TE can show it as well. CT is the gold standard, and it demonstrates the type B aortic dissection in this case. How to treat these dissections? In most cases, unless there is involvement of the major branches like the renals or the SMA, conservative treatment is done with analgesia and controlling the blood pressure, and this is what was done in this particular patient. And of course, PCI was postponed and should be postponed until after the dissection flaps are healed. Thank you.